Welcome to Dr. Madhu's MedEd International, where we bring you clear, clinical, and concise concepts. Let's get into today's lesson. Delirium is the commonest organic mental disorder seen in clinical practice. It is characterized by a relatively acute onset, clouding of consciousness, and a fluctuating course. It is the preferred clinical term for various conditions previously known as acute confusional states, toxic psychosis, or metabolic encephalopathy. Prevalence. It is estimated to develop in 5% to 15% of all patients in medical and surgical inpatient units. Postoperative. The incidence is significantly higher in postoperative patients. The etiology follows a threshold phenomenon, where a combination of factors adds up to cross an individual's specific threshold for delirium, biological predisposing factors, extremes of age, very old or very young, pre-existing brain damage or dementia, previous history of delirium, chronic medical illnesses or generalized cerebral lesions, alcohol or drug dependence. Precipitating factors: metabolic, hypoxia, hypoglycemia, hepatic or uremic encephalopathy, electrolyte imbalance, endocrine, hyperthyroidism, pituitary or adrenal dysfunction, infections, systemic septicemia, pneumonia or intracranial meningitis, encephalitis, drugs or poisons, anticholinergics, TCAs, digitalis, L-DOPA and alcohol, sedative withdrawal, nutritional deficiency, thiamine B1, niacin, B12, or folic acid, social or environmental, surgical procedures, and the postoperative period, admission to restrictive settings like the ICU. Clinical features. Symptoms often show diurnal variation. Typically, symptoms worsen in the evening and night, a phenomenon known as sundowning phenomenon. Acute onset. Rapid development of symptoms. Clouding of consciousness. Decreased awareness of the environment and reduced ability to respond to stimuli. Disorientation, primarily in time, then place, and eventually person. Perceptual disturbances, visual illusions, misinterpretations, and visual hallucinations are common. Cognitive impairment, decreased attention span, distractibility, and impaired registration/retention of new memories. Sleep-wake cycle disturbance, insomnia at night with daytime drowsiness. Emotional lability, rapidly shifting moods or inappropriate affect. Signs: asterixis, also known as flapping tremor. Carphalogia or flocculation, picking movements at bedsheets or clothes. Occupational delirium, elaborate pantomimes acting as if the patient is performing their usual job. Multifocal myoclonus, rapid, involuntary muscle jerks. Autonomic dysfunction, tachycardia, sweating, and dysarthria, slurred speech. For a definite diagnosis, ICD-10 requires symptoms in each of these 5 areas: impairment of consciousness and attention, clouding to coma, global disturbance of cognition, disorientation, memory impairment, psychomotor disturbances, agitation or retardation, disturbance of sleep-wake cycle, insomnia or nocturnal worsening, emotional disturbances, depression, anxiety, irritability. Duration: usually much less than 6 months. Differential diagnosis. This table compares delirium, dementia, and schizophrenia across several key clinical features. First, looking at consciousness. In delirium, consciousness is clouded. Patients are often confused, inattentive, and fluctuate during the day. In dementia, consciousness is usually clear or normal, especially in the early stages. In schizophrenia, consciousness is also clear, even though thinking and perception may be disturbed. Next, the onset. Delirium has an acute onset, developing over hours to days. Dementia has a chronic, gradual onset, progressing over months to years. Schizophrenia has a variable onset, often developing gradually in late adolescence or early adulthood, but it can also present more abruptly. Moving to hallucinations. Delirium commonly involves visual hallucinations, such as seeing insects or people that aren't there. In dementia, hallucinations are rare early on, but may appear in later stages. Schizophrenia is classically associated with auditory hallucinations, such as hearing voices. Finally, Reversibility. Delirium is usually reversible once the underlying cause, such as infection, medication, or metabolic imbalance, is treated. Dementia is not reversible, as it involves progressive neurodegeneration. Schizophrenia is also not reversible, although symptoms can often be managed with long-term treatment. Overall, this comparison helps distinguish delirium as an acute, reversible condition from the more chronic and typically irreversible disorders of dementia and schizophrenia. Management. First priority: correct reversible biological causes immediately. These are life-saving steps. Do not wait for investigations. Hypoglycemia. Give 50 milligrams of 50% dextrose IV bolus. Restores cerebral glucose rapidly. Always check blood sugar early in altered sensorium. Hypoxia. Start oxygen supplementation immediately. Aim to maintain adequate oxygen saturation. Hypoxia can rapidly worsen confusion and brain injury. Thiamine deficiency. Give vitamin B1, thiamine 100 milligrams IV, especially important in alcohol-dependent patients. Crucial clinical pearl. Always give thiamine before glucose in alcoholics. Glucose without thiamine can precipitate Wernicke's encephalopathy. Pharmacological treatment. Antipsychotics, low-dose haloperidol or risperidone are used for agitation. Warning: there is an increased stroke risk in elderly patients with dementia given atypicals. Benzodiazepines. Lorazepam or diazepam. Note: lorazepam or diazepam can be used, particularly in alcohol withdrawal-related delirium. Supportive care. Nursing care for hydration, nutrition, and prevention of injury. Environmental cues. Keeping clocks and windows visible in the ICU. To maintain orientation. Prognosis. Usually recovers within 1 week, though it may take up to 1 month. Delayed recovery. Complications. If the diagnosis is missed or treatment is delayed, permanent and irreversible deficits can occur. Delirium is a medical emergency. Delay leads to permanent loss. Demonstration of asterixis, the flap. Step 1. Explain to the patient. Ask the patient to sit or stand comfortably. Explain: I'm going to check your hand posture. Please follow my instructions. Step 2. Position the arms. Ask the patient to extend both arms forward, arms at shoulder level, palms facing downwards. Step 3. Dorsiflex the wrists. Instruct the patient to bend the wrists upwards, dorsiflexion, spread the fingers apart. Maintain this position. Step 4. Observe carefully. Observe hands for 15 to 30 seconds. Look for sudden, brief loss of wrist posture, followed by immediate return to dorsiflexion. Step 5. Identify the flap. The movement appears as irregular, non-rhythmic jerks, a brief dropping of the hands, then correction. This is the classic flapping tremor. Step 6. Interpret the finding. Presence of the flap indicates asterixis, suggests metabolic encephalopathy. Asterixis is a negative myoclonus caused by intermittent failure of posture maintenance due to metabolic strain on the brain. Asterixis is not a true tremor. It reflects impaired cortical motor control. D. Disorientation. Time, place, person. E. Emotions. Labile. Rapidly shifting moods. L. Low attention. Poor focus and concentration. Core feature. I. Illusions, hallucinations, mainly visual. R. Rapid onset. Acute, fluctuating course. I. Insomnia. Sleep-wake cycle disturbance, sundowning. U. Utter clouding. Reduced awareness and consciousness. M. Motor signs. Asterixis, carphalogia, agitation, or retardation. Commonly asked Viva questions. What is sundowning? ANS. Worsening of delirium symptoms in the evening/night. How do you differentiate delirium from dementia on examination? ANS. Consciousness is clouded in delirium and clear in dementia. What is the diagnostic significance of an EEG in delirium? ANS. Usually shows slowing of background activity. Common mistakes students make. Labeling as normal confusion. Assuming postoperative confusion is just a normal reaction to surgery rather than investigating for delirium. Oversedation. Giving high doses of sedatives which can worsen the clouding of consciousness and deepen the delirium. Ignoring the underlying cause, treating the agitation with drugs while forgetting to check for simple triggers like a full bladder, hypoxia, or hypoglycemia. Thanks for watching. If you found this helpful, please subscribe, like, share, and comment for more clinically clear medical education.